This is the Psychcast by MD Edge, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and relevant inspiration, with new episodes dropping on Wednesdays. I'm the voice of MD Edge Podcasts, Nick Andrews. This week, Dr. Michael Myers hosts a conversation with Dr. William Lynes. Dr. Myers is a clinical psychiatrist who specializes in physician mental health. Dr. Myers and Dr. Lynes discuss the lived experience of burnout and mental health issues as a healthcare professional, including attempting suicide. You can find more information about our host and his guest in the show notes, courtesy of Dr. Jacqueline Posada. Don't forget that you can listen to any of our previous 101 episodes by subscribing to the show wherever you listen to your podcasts. Okay, we'll get right into this harrowing story with Dr. Mike Myers and Dr. Lynes.
I'm Dr. Michael Myers. I'm a professor of clinical psychiatry at SUNY Downstate Medical Center in Brooklyn, New York. I'm also a specialist in physician health. My most recent book is Why Physicians Die by Suicide, Lessons Learned from Their Families and Others Who Cared. And this is how I've come to know the man that I'm about to interview, Dr. William Lynes. Dr. Lynes wrote me a letter last June in which he described his experience with burnout, depression, and suicide attempts. I reached out to him, and here we are today. But before I introduce him, I want to take a minute to define and comment on the term lived experience. Individuals with lived experience are people who have suffered from psychiatric illness, often with suicidality, who have made the brave decision to go public. In other words, to talk about it, to write about it, and to selflessly help others. I'm certain that individuals listening to this podcast, mostly mental health professionals, share the sentiment of gratitude. They are our friends, our allies, in our fight to reduce the stigma attached to mental illness. And this is why I'm delighted and honored to be talking to Dr. Lynes. Dr. Lynes lives in California. He obtained his MD from the University of Texas in 1981 and did his surgery and urology residencies at Stanford University Medical Center. He then went to work for Southern California Kaiser Permanente Medical Group in Riverside, California from 1987 until 2003. He is the author of 7 published works of fiction, numerous short stories, and articles in the Annals of Internal Medicine and Kevin, MD. Welcome, Dr. Lynes.
Thank you, Dr. Myers. It's an honor to be here.
Okay, let me start. For those listeners who haven't read your gripping piece called The Last Day in the Annals of Internal Medicine, can you tell us about what led up to your suicide attempt in 2003?
Yeah, I'd be glad to. Let's talk about the period of time from my end of my residency, which was 1987, until my retirement in 2003, because I can divide that period of time into 2 distinct eras. The first, from 87 to 98, I had what I call a happy, busy, successful urologic practice and really life. But then something happened to me in 1998, which I'll mention, and I began in 98 what I call a downward spiral into darkness, darkness being a code word for me for suicidal behavior. What happened to me in 1998 is I experienced septic shock after a family vacation abroad. And when I went to the emergency room with shaking, chills, and fever, I ended up being admitted and intubated on a ventilator within an hour or so. I ended up being in the intensive care unit for 6 full weeks. I was on a ventilator for 4 weeks. I had all the manifestations of sepsis. I had a tracheostomy. I lost 40 pounds. I had chest tubes. I had organ system failures. And I really had very, very bad ICU psychosis. So when I recovered from that and I rehabbed, I went back to my practice 9 months later. And then, unfortunately, about 2 years later, I was on a family vacation again and had a snowboarding accident, had severe facial fractures. I had 5 facial surgeries. I had a tracheostomy again. I lost 40 pounds again. This time I rehabbed and went back to work 2 months later. The problem is when I went back to work, I was not the same. And in ways that some are hard to describe, but I feel that you age when you go through something like that. I may have been 45 when I became septic, but I was more like 55 or 60 physiologically. I responded very poorly to stress. Long surgeries and overnight calls were very problematic. The excitement from my practice was gone, and I had been excited. I had really enjoyed being a physician, but it was gone. And I lacked confidence, especially surgical. And I, interestingly enough, had a really hard time, especially at the end, telling patients bad news. Now, I started seeing psychiatry right after I had septic shock, which again was in September of '98. And they feel that I have bipolar II affective mood disorder and began me on a series of various treatments, which we can talk about. So I found myself depressed, despondent, really hopeless. Everything I tried to do to make myself better made myself worse, and that was more depressing. I crossed a finite line in my evolution, suicidal evolution, one day, and I can remember the day and the place where one moment I thought that suicide was not for me, it was repulsive, and the next moment I thought, well, it's really not that bad. I didn't start planning at that moment, but I accepted it. I put a lot of internal pressure on myself to practice and to succeed. It's just typical of me, but I wanted to be a physician. I was proud of being a physician, and so I did that. There was a little bit of external pressure from the partnership, which I mean the Kaiser Permanente partnership, and I can talk about that later. But at the end, suicide became really what I say is a irrational decision based on very much economics. I didn't think that I could swing taking care of my family on a retired income. So I had quite a bit of life insurance, and one very sad day I called insurance carriers and questioned them about whether or not they would pay for a suicide. Turns out that they would. And so at that point, it was a financial decision that said that I was worth more dead than I was alive. And so those are some of the thoughts that I had leading up to my suicide attempts.
Wow. Bill, that's quite a story. Gosh. Yes, I mean, so much, physical trauma. And then, that, as you mentioned, the ICU psychosis and then the depression afterwards. And also, I guess, a sense that even when you return to work between, 1998 and 2001, I think I heard you say that you really didn't feel back to your old self or even a new self, that you were still, it sounds as if you were still pretty wobbly, no?
Yes, very much so.
Bill, I'm going to fast forward to where you were then when you took those various factors into consideration. And when you attempted suicide in 2003, and I remember from the article that this occurred in your office, correct?
Yes, it did.
Bill, would you tell us a little bit more about that?
Well, in 2003, I decided to end my life, and I needed a private place. And in retrospect, it's not a good choice to select your office. but I went on a Saturday to my office, and my office was in the clinic, the urologic clinic, but it was closed. It was very private and dark. I went into my office and locked the door. I remember looking at my reflection in my medical school diploma and feeling how disgusted I was about myself. I had brought a bottle of whiskey, and with the whiskey and with lidocaine, I anesthetized myself and made an incision in my wrist. And then I laid down on a air mattress on my floor of my office, to die. And I fell asleep, and I must have slept for about 13, 14 hours. And when I woke up, the bleeding had actively stopped. There was blood all over. It was like a battle zone. I had lost 4 or 5 units of blood. I was really orthostatic with low blood pressure. But I thought, in my physician sense, that, you're not going to die. And so I wondered what to do. I very, very reluctantly called the hospital operator, described the situation and where I was, and then with overwhelming, massive humiliation and tremendous shame, I was admitted to the hospital. Again, this is the hospital where I practiced at, and I had surgical repair of my wrist. But the story, what I had done to myself, really, it went around the medical center. Everybody was talking about it. It was quite an event. So from there, I recovered and rehabbed, I had before begged and cajoled people to let me practice, but in 2003, now this is the third suicide attempt that I've had, there really was no question in my mind that I needed to retire, and the medical group would not condone me practicing. So that's basically what happened that day.
Bill, let me ask you something. You know how you use these words a couple of times at that moment that you awakened. You used the term that you felt deeply humiliated, you felt ashamed, and then, as you say, you were treated in the hospital where you worked. I have a question. Was the humiliation and shame that you felt, was that largely related to the fact that this was, the place where you work, or was there a part of humiliation that you felt somehow embarrassed about not dying, or about attempting suicide, or something like that?
Yeah,
I asked you that because I've heard that from my doctor patients before.
Yes, tremendous humiliation, which came from myself, of being embarrassed to be a suicidal patient, to be having mental health issues like I did. I felt also that I had let my medical group down, which I had been with them for a long time and was very proud about what we had built. I remember talking to the chief of urology, is a very dear friend of mine, and telling him, but what about the medical group? What about the department? He said that that's okay, but I didn't think it was okay. So it partly, I think, doing this in your office, it was a horrible, horrible decision, and it's part of the humiliation that I felt. But a lot of it is baggage that I carried for a long time. Throughout the years, I felt very embarrassed about having trouble getting to work and performing my duties. I imagined that people were talking about me and so forth. So that's sort of what I was thinking.
I see. I understand. Obviously, you're being very, very hard on yourself.
I was being very hard on myself, yes.
Yeah. Bill, you told us a little bit already about the care that you received, like earlier for your septic shock, and then also the care that you received after your snowboarding accident. Tell us a little bit about the care that you received then, like in the hospital, like the psychiatric care that you received.
Yes, I have had a lot of what I call pharmacotherapy, antidepressants and so forth, mood stabilizers. So I estimate I've been on maybe 100 different regimes through the years.
Wow.
I was even on a monoamine oxidase inhibitor at one point with catastrophic side effects. I've had some psychotherapy, if we mean by that talk therapy. I have had just one psychiatrist now for over 20 years. I see him now once a month. And he's become my friend, but he was a great counselor through all of these years. I've had some group therapy when I was in locked psychiatric wards. I was forced to do that. I didn't do well with it. So that the other thing that I've had a lot of is electroshock therapy, or ECT. And I've had, I believe, somewhere between 30 and 50 treatments. I even had maintenance therapy during a period of time where I was trying to work. So those are the three mental health type of therapies that I've had.
Okay. It's been quite a journey for you, Bill. You haven't used this word, but it's implicit in so much of what you've said. And so that prompts my next question, which is, talk about stigma and its role here in your life.
Well, stigma is very real, and I think we all, as medical professionals, hope that things are getting better with that. But I have my doubts. In terms of me, I can divide stigma into two types. First, the most powerful type, perhaps, is your own self-induced stigma, your embarrassment, your disgust with yourself, and so that's one type. The other type is externally from society and the medical profession. They're embarrassed. They'd rather not talk about this subject. It's a dirty little subject, and so stigma, I think, is very real. Attention that we're giving to, like with this podcast, physician burnout and suicide, however, for me is very promising, and I hope that things will get better.
I think that your decision to talk about your illness and its treatment is a gallant one, and I thank you for that.
Thank you.
Tell us about that process. Tell us how and why you decided to write and lecture about something so deeply personal and, as you've alluded to a moment ago, stigmatized in the House of Medicine.
Well, from 2003, really beginning, after I went back to work with septic shock, I mean, I really didn't do well. And with my retirement, I stopped fantasizing about suicide, but I didn't do well. One thing that really, really bothered me is I basically thought that I wasn't a physician anymore. I didn't associate with physicians. I was scared to be around them. And I went to a physician writers conference in Taos, New Mexico. This was the summer of 2015. And I met a female fellow physician, who was also a fellow burnout survivor. And she let me read an essay that she wrote and had published in the Annals of Internal Medicine, which she confessed her problems. And she told me that she was so relieved after doing that, and she recommended that I do that myself. And I actually came home, again, summer of 2015, and within a week, I had this essay written that just sort of spit out of me. And I was lucky in that very quickly it was accepted in the Annals of Internal Medicine, published February of 2017. I had the same experience as she did. I felt totally relieved, a lot of relief. I wasn't embarrassed of myself anymore. More importantly, I began to associate with the medical profession again, and that was very joyful. I began to speak on physician burnout and suicide. So I had a very good response to that. And and one thing objectively I can tell you that happened, sort of an objective measurement, I had a recurrent bad dream from at least the time that I retired in 2003 on. And I would have it really about every week or every 2 weeks, and it was always the same theme, that I was trying to practice medicine but having a lot of trouble, and it was quite distressing to me. And you know that since I have confessed and with my article and so forth, I haven't, luckily, praise God, had that dream anymore. So it sort of objectifies the measurement of my improvement.
Bill, I love that story. I think it's really beautiful.
Thank you.
So what you're telling us is that largely it's been really positive, right?
There is no negatives. I've tried. I knew that maybe we would ask that, and I can't think of a negative for me. Yes, it's all been positive.
That's really nice to hear, because I think that there are a lot of people who are considering telling their story, even if it's to just colleagues. They may not write about it, but I think that largely the relief that you felt, as well as all of those other parameters that you just listed, are very, very powerful.
Yes. Thank you.
So, Bill, as you know, we touched on stigma earlier. So I'm wondering if you think that there's the beginning of a sea change in medicine, that more and more doctors are coming out, if you want to call it that, coming out and talking about their own journeys. What are your thoughts about that?
Well, I think that there evidently is some improvement, some reduction in stigma, but I think that it's not very prominent. I'll give you a recent example. I spoke at a hospital, and a day or so afterwards, a resident who was evidently in the audience emailed me, and he was thinking about suicide. He was burnt out, and he was very, very concerned about not getting a fellowship because of his mental health issues. He was afraid, and I don't think this is right, but he was afraid that if he took a SSRI, drug screens would flag him to people. He was afraid that his credentials and license might be somehow compromised. And the poor guy, I communicated with him from email, about 5 or 6 emails, in fact, just even last week. And, you know, he never has answered me. And I don't think, I hope it isn't that he committed suicide, but his email address still works. It doesn't bounce. So I think he had second thoughts about talking even to me. So that's like a modern example of where stigma is. I think it continues, unfortunately.
Right, and let's hope that actually you had more of a positive impact than you're actually getting. I mean, I understand you're thinking about that, but, you know, hopefully just even your responding to him is actually helpful for him. So,
yeah, perhaps he was benefited more than I know. Yeah.
Mm-hmm. Mm-hmm. I want to ask you something else. I've heard some physicians tell me that they're fairly open with colleagues about having suffered from depression and that they've been helped, with treatment. But some of them have actually literally whispered to me that they don't share that they attempted suicide. See, do you have any thoughts about that? Like, what I'm wondering if that might be yet another facet of stigma.
Well, yeah, I think it's a step up. I think that a suicide attempt, less so thoughts of suicide, but a suicide attempt is really sort of the ultimate thing to confess for all the reasons that we've talked about. For me, though, I had to confess, open up in order to heal. I think it is, and it goes back to the improvement that I've felt, and but we need to do something to help people to be able to open up, both to their colleagues and to society in general.
Yeah, and Bill, you preempted my next question because we just have a few minutes left. But I want you to have some time to make some concluding remarks. First, I'm interested in knowing what recommendations you might have for those listening to this podcast who themselves are not feeling well and are worried about their mental health. Any thoughts, suggestions?
I've given it quite a bit of thought. First of all, I think statistically, and you could comment on this better than I think therapy, psychotherapy and pharmacotherapy are the only things that have really shown a benefit in physician burnout, depression, suicidal thoughts, and so on. But we need to be able to get a therapy out of our peer group. At Kaiser, they have what's called alternative mental health insurance. What it allowed me to do is to go to a private doctor outside of the medical center, not one of my colleagues, and interact with him. And I think that sort of from the medical profession's point of view, all medical groups, partnerships, need to have that built into their health insurance plans. I think it's important to open up to colleagues as much as you can, but you need to be cautious. There are individuals that, the bottom line is that they will stigmatize you. I didn't do that, but in retrospect, I wish I had. I have the chief that I mentioned. He's a dear friend, and he really could have helped me and counseled me. I think ultimately you need to make lifestyle changes. It's not healthy to be a 24/7 doctor, and you need to have exercise, family, spiritual input's important to me in your life, making you more well-rounded. I am a big believer in what's called narrative medicine writing. And what that is just writing about your experiences in medicine. Now, I write fiction novels. You don't need to do something that extensive. I'm talking about just journaling or a daily diary. It seems to be beneficial somehow that you write about your experience. I think that ultimately the physician needs to realize that sometimes, unfortunately, you have to stop your practice in order to survive. I'm a good example of that. I wouldn't have survived if I'd continued practicing. So those are some of the thoughts that I've had in terms of recommendations to those who are in my same situation.
Okay. Thank you, Bill. And another question I have for you are for those listeners who treat doctor patients. Any suggestions there? Do you think in some ways we're different than non-physician patients?
I think that we are different. First of all, physicians deal with life and death issues all the time, and that makes you different. Patients depend on their physician so much, and more so than other professions, I think. I think, interestingly, physicians like to treat themselves as well. I did, and that must be sort of frustrating in regards to your counseling and helping someone. So those are some of the things that I think that make treating physicians different. I don't have a lot of recommendations on how to do that. I may have treated a physician urologically once or twice, but you, of course, have dedicated your life to treating physicians. So, but I don't have any answers about how to do it. But those are some of the things that make physicians unique.
Thank you, Bill. I like that very much. The last question I have for you actually is more of a personal one with regard to this other chapter in your life. I understand that your next book A Surgeon's Knot, is coming out in April.
Yes.
I wonder if you could why don't you just tell us just a little bit about it?
Well, it is the title comes from a knot that people use in surgery, but it refers to as well sort of the tangled world of medicine and surgery that the protagonist finds himself in, the knotty world, if you will, N-K-N-O-T, not N-A-U-G-H-T. And his name is Jackson Cooper. He's a young physician who has the privilege of having an internship at a prestigious Northern California medical center called University Medical Center. It's set in 1981 and 82. I've tried to make it, start right from the beginning with facts about medicine. He has a unfortunate patient event happen on his very first day, which he is responsible to take care of, and he's not prepared for that, and he's especially not prepared for the job of having to counsel and mourn with the family. So his life through this year of internship, for self-imposed reasons as well as from the system, but he partakes in some destructive behavior, and he becomes burnt out. And it's a story of the dignity and nobility of medicine, but also the other side of some terror, a lot of tragedy associated with it. And so, yes, it comes out in April. It's by Black Rose Writing.
Thank you very much, Bill. I'm looking forward to reading it. I think it's going to be a wonderful read.
Great.
So, in summary, we've discussed the many factors that come together all at once in a physician that drives or can drive a self-destructive act. We've described the role of both internal and external stigma regarding psychiatric illness in physicians. And we've listed the ways that physicians with lived experience are changing the way that medicine is being taught and practiced in the United States. We hope toward a more humane understanding of personal vulnerabilities and help seeking. So, Bill, thank you very much for your time today. I really appreciate this.
Mike, thank you for your time and also for your association over the last year. I want to say to you that it's an honor to know you, and I'm very complimentary to you about your dedication in your life to treating at-risk mentally health victims of physicians and their suicide. And if I could, I typically end with this is sort of a black subject. We've talked about depressive sort of things. And the thing is that medicine is a wonderful profession. And so I like to end with, I call it a pep talk. And what I did is I believe that practicing medicine is a noble profession. And I've taken 9 other synonyms, and it seems so powerful to just read them.
Right ahead.
The practice of medicine is noble. The practice of medicine is honorable. It is moral. It is decent. It is upright. Practicing medicine is proper. It is good. It is ethical. It is right. It is worthy. And with that, thank you very much, Dr. Myers, for everything you've done for me.
Thank you, Dr. Lynes.
And that concludes this edition of the Psychcast by MD Edge. You can find, of course, robust show notes available wherever notes are found in your particular podcast app. The Psychcast is produced by Editor-in-Chief of MD Edge Psychiatry, Dr. Lorenzo Norris. Our guest host this week was Dr. Michael Myers, and our interview guest was Dr. William Lynes. The show notes are authored by Dr. Jacqueline Posada. The Psychcast is produced by Gina Henderson and Jeff Bauer. All MD Edge podcasts are produced by our editor-in-chief, Dr. Ivan Aransky. MD Edge executive editors Kathy Skarbeck and Mary Ellen Schneider, as well as multimedia editor Terry Rudd. Social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MD Edge podcasts, Nick Andrews. Thanks for listening to the Psychcast by MD Edge.